Good afternoon, everybody. We're so happy that you're here with us today. We're really excited to share with you the primary care wins and also lessons learned in the 88th Texas legislative session. And we're going to examine the impacts on our primary care system. Our speakers today, I'm Sue Bornstein. I'm the co-lead of the Texas Primary Care Consortium. Ankit Sanghavi, who's executive director of the Texas Health Institute, and also my co-lead for the Primary Care Consortium. Honorable Larry Gonzalez, who's the president of Desk 138. He is our legislative consultant. And also Valerie Borum-Smith. Dr. Smith is assistant professor of pediatrics at the University of Texas at Tyler. She's also the health authority for Smith County. So our goals today are to describe our successful efforts during the recent legislative session and to share the lessons learned. You will hear that we had, I think, quite a few wins. We don't always win the first time around, but we do learn lessons on how to do things better and to have more wins in the future. Then we're going to discuss strategies to build on our current situation during the interim period. This is a really important part because as soon as the legislative session is over, the plans start for the next one. So for the interim charges and the like, and also it's a critical time because this is the rule-making time. So we cannot take our eye off the ball. And then finally, we're going to identify next steps to continue to advance the high-quality primary care in Texas. So Texas Primary Care Consortium is a statewide collaborative initiative. It is the only statewide collaborative initiative. Our mission is to advance equitable, comprehensive, and sustainable primary care for all Texans. We are co-led by the Texas Medical Home Initiative and the Texas Health Institute. Well, how do we do our work? We do our work by the framework of the educate, activate, and transform. Educate. We expand our knowledge base by sharing best practices, lessons learned, and replicable tools. And that's what we're doing today. We activate. We facilitate opportunities to build and strengthen lasting partnerships for shared and sustainable impact. And finally, we transform. We create spaces for dialogue and action to generate a shift in the healthcare system through policy and system change initiatives. We could not do this work without our generous supporters and partners. We want to acknowledge the role of the Episcopal Health Foundation, St. David's Foundation, Texas Academy of Family Physicians, and the TMF Health Quality Institute. So thank you to our partners. This is our team. Our team keeps expanding, and we're happy about that. I have the honor and the privilege of coming to work every day with a tremendously talented group of people that really are making things happen. It's really a delight to work with this team. So let's talk about primary care. So why primary care? Well, a number of reasons. Primary care accounts for close to 50% of professional office visits every year, and it influences up to 90% of total healthcare costs through referrals, testing, procedures, and hospitalizations. However, the little orange dot at the bottom, primary care spending nationally only is about 5 to 7% on the average of total healthcare spending. And we've known for a long time that that is woefully inadequate. All it took was a pandemic to really shine a bright light on how chronic underfunding of primary care combined with the prevailing fee-for-service payment structure was really not conducive to sustainable primary care. So again, there's a big mismatch between our influence and the spending on primary care. So let's talk about Texas. Well, here's some statistics. Medical debt is higher, significantly higher in Texas than it is nationally. And we think that primary care, good access to affordable primary care can really have an impact on that, positive impact. 15% of our fellow Texans went without care because of costs, and that's higher than the national average. This is a very troubling statistic. 27% of Texans do not have a primary care practitioner. And we know that that is not good for their health. That's not good for the health of their communities. And Texas ranks last in the country in access and affordability, and not very well either in avoidable hospital using costs. And again, this can be tied back in large part to the lack of access to affordable primary care. Well, we in Texas, as you are all very aware, lead the nation in something that is not a very enviable category, and that is the most uninsured. It's estimated that there's around 5.2 million uninsured Texans. That is at least twice the national average. And so why is this important? Well, it's important for a number of reasons. One is uninsured status tends to prevent people from seeking primary care. They may ultimately seek care in a less appropriate environment, such as an emergency department, where it is going to be more costly. And so that is one effect of lack of insurance. And this is not a monolithic state, as we all know. And the uninsured are not a monolithic population. 27% of Hispanic Texans are uninsured, compared to 12% white Texans, 18% of Black Texans. And we also know that this has geographic variation, significant. Along the Texas-Mexico border, the rates of uninsured can exceed 30%. And another very troubling statistic is that close to 12% of Texas children are uninsured, compared to 5.4% nationally. And that was before the unrolling of Medicaid that's happening recently. Well, another reason that primary care is important in this state is that almost 4 million Texans live in rural areas. That is more than any other state in the country. 32 counties have no primary care physician. 75 counties have no physician assistant, and 28 counties have neither. And Texas is leading the country in rural hospital closures. And so that presents its own set of challenges in terms of emergency care and obstetric care, et cetera. So I just presented some concerning statistics, concerning information, but the good news is that we at the Primary Care Consortium, and you, because you're participating on this call today, we believe that we can do better, and we believe that we have to do better here in Texas. Our Texans deserve it. And so I'm going to now turn the program over to Ankit Sanghavi to recap the 88th legislative session.
Thank you, Sue. Good afternoon again, everyone, and thank you for joining us here at the Primary Care Consortium. Before I kind of go over the story for us with the regular session of the Texas Legislature for earlier spring, summer this year, and more importantly, set into context or charting the path forward, where do we go from here? Just want to take a couple minutes to, for those of you relatively new or just joining the consortium, a quick background or context on how we approached advancing or strengthening primary care during the 8th legislative session. Both are strategies, in many part the principles that we took into account as we were identifying and advancing policy priorities, and hopefully share some of the successes and lessons learned. So as a consortium, as your consortium, there were three, if I may say, important levers or principles that were kind of the backbone or founding of the policy options and strategy. We were able to put this together. Those three being, we wanted to be forward-looking and solution-oriented as we thought about identifying those opportunities or solutions to address some of this chronic long-standing challenges. The second was leading with a consensus-based approach, given that the solutions that we seek for many of these problems, they are very interconnected. And as a consortium, we wanted to make sure that we were advancing a culture of collaboration, coordination to truly realize our vision of primary care as we advance policy agenda. And the third principle of being objective and grounded in data and science of primary care and health system transformation, as we all know, and as it continues to evolve. So with those fundamental, I would say, value construct or approaches, and through a rigorous process that I am grateful for the 16 individuals for their organizations who participated in our consensus panel for a good part of a year preceding to the regular session this January. Through a series of discussions and ongoing engagement, review, interacting with national and state level subject matter experts, we were able to identify a number of policy options or strategies that we sought the legislature's attention and support for during the regular session. For the sake of brevity, we would categorize our policy options into the three buckets of the most acute, if I may, needs being around access to care, which again are reflected in many of the data points or statistics that Sue went over. Starting with reducing the number of uninsured Texans, but at the same time, as we seek having more insurance coverage and options for all Texans, ensuring that there are enough primary care physicians and care points to make sure that they are receiving accessible and timely care, preventing those needs or taking that prevention first approach. In addition to that, looking at our infrastructure to ensure that we are able to sustain that network adequacy and grow, hopefully in that process. And again, as a silver lining through the pandemic has been the acceleration or adoption of technology and telehealth in particular, and identifying ways with 3 years of the pandemic, telehealth being in use, we have a good sense of what tends to work, what does not work, and ensuring that we are learning and building upon that foundation. The second bucket, as we look at addressing the chronic issue of rising healthcare cost or for healthcare to be sustainable, is the focus on moving from fee-for-service to value-based payment model and efforts. And again, looking at what is needed from an infrastructure and a system perspective, but also what are some of those models or solutions that we know are working, or we need to probably test them for feasibility to scale and replicate for more than one population group or geography. And then lastly, again, given our mission and looking at our pursuit of making healthcare or primary care accessible and affordable for all Texans, we seek to strengthen primary care. And again, even earlier this morning, we just talked about a story last night, which again featured nationally on the shortage of primary care across the country. And we'll use that as part of the discussion, or we'll come back to that as part of our discussion today and charting the course forward. But looking at how can we systematically and in an organized way pursue strengthening primary care within Texas to meet the needs of access, cost, and improved health outcomes. Next slide. So going into the session with those policy options, again, taking that solution objective outlook and looking at with a forward-looking approach. Pleased to share that we had several wins, and I must say that while the coalition is and consortium has been grateful for the opportunity to engage, interact with many of our partners, a lot of these policy wins that we see are an outcome of efforts beyond the consortium, many other population-specific groups or topic-specific groups that have been advocating, not just during the session, but years leading to the session. So this has been a collective undertaking, and we have been grateful for the opportunity to formally, informally coordinate, support, inform many of those policy efforts and decisions during the discourse of the legislative session, which ultimately do play a role in strengthening primary care. The biggest wins, I think, where we had, or the largest distance we covered, was around access to care. Some of the options you see here is HB 1575, which is looking at an additional resource or strengthening the ability for case managers, navigators to address the non-medical drivers of health or those needs for pregnant women in Medicaid, looking at the role of CHWs and doulas. HB 12, which I think has been the takeaway from this session, it took its own course. I think a pursuit that took about 6 years at the bare minimum to be realized, but nevertheless, we were able to accomplish it this go round. And again, it's truly been a collective undertaking, and TPCC was proud to lend its voice and perspective in supporting that outcome, with Medicaid expanding to 12 months for postpartum women. HB 3359, which ensures patients have a sufficient panel of in-network, not directly implied on primary care, but just looking at, again, that network adequacy and follow-through piece when I think about the care continuum. SB 30 provided an additional $15 million to the FQHC incubator program. Again, when we think about the uninsured population or addressing challenges to access to care, we are really talking about how do we strengthen a strong safety net in Texas, and FQHC play a foundational role when we think about the safety net infrastructure in the state. And again, this investment is a step in, again, further strengthening that foundation. And SB 2193 seeks to establish a pilot project for uninsured working adults. Again, when we think about the uninsured population, it is a significant number, almost 20% of our state's population. And as a growing state, when you unpack the uninsured population pie, we do need to look at a package of solutions that truly solve that problem comprehensive for the full population. But again, 2193 is a step in that direction in identifying what that strategy or sets of strategy may look like. Next slide. In addition to access to care, we also had a few wins as it relates to our long-term pursuit of strengthening primary care with HB 3414. While the legislature in 2021 did approve the creation of a APCD, all-payer claims database, 3414 has created or added an element of governance and the ability for groups such as THI, TPCC, and many other research and academic institutions to utilize the data that's available through the all-payer claims database to, again, allow us to unpack trends when it comes to utilization, when it comes to spending, and again, identifying or answering many of those questions that are critical in finding those cost containment strategy for sustainable healthcare. And then within the budget, there were several places for increasing investment in primary care training programs, and more importantly, going back to the network adequacy piece. After more than a decade, if I'm not mistaken, a 6% increase for physicians treating children in labor and delivery, which was really part of an HHSC request. So really appreciate their support going into the session and legislature approving and supporting the same. With those wins, this as being our first formal session of putting forward a primary care policy agenda, we also were looking at this as a learning opportunity to identify what things work, what things do not work more so, and how can we continue to loop that into our processes, into our approaches and strategies as we seek to look at what would it take in the long run to sustain on the progress that we have made, but to create pathways for additional successes such as accomplished this session. So with that, we looked at what didn't pass. HB 1599, express lane eligibility. And if you really want to look at uninsured within access to care, we were looking at the population, or the focus has been on Medicaid expansion. But when we look at the uninsured pie a bit closer, while about 17% of the uninsured population in Texas could benefit from Medicaid expansion, just a little bit short of that, about 14 to 15% falls into the bucket of what we can identify as eligible yet uninsured. And HB 1599 is a step in that direction that was going to help bring that eligible yet uninsured number a bit lower, and something that TPCC is interested in in learning from what didn't work and how do we overcome that as we look into 2025. Again, we'll talk a bit more as we progress in today's discussion. HB 1073 with a focus on value-based care. We got close on the House side, but couldn't see it through on the Senate. And again, lots to unpack in terms of what didn't work and what we may want to pay attention to. The other one was by Dr. Oliverson on HB 2983, that is a food as medicine pilot that seeks to address or test a model that can allow to address food, especially for those high-risk population with diabetes or with food insecurity challenges. In addition to that, from a process perspective, and for those of you in the advocacy space may relate to this, is that it is not just the engagement during the session, what as a consortium, and as we look at this in the long-term horizon, continuous engagement, not just during the session, but leading to, and more importantly, during this next 15 months before they get back into a regular session in 2025, being there, being available as a resource, as a thought partner, informing, responding to the questions. Sue mentioned that we are in this important phase, which is also rulemaking, and again, following through on many of those conversations are some of our lessons, and we seek to respond and trying to be more proactive than reactive. And again, as a consortium, going into the session with the lens of objectivity, being a resource, a thought partner to our allies and colleagues outside the Capitol, but also within the Capitol with our interactions and outreach with legislative leaders and their staff is what we have identified as things that worked and we can do more of as we seek to forward solutions or push forward solutions that, again, look at this with building upon the foundation that is already there and are grounded in evidence, are grounded in science, and more importantly, there is consensus that we have been able to build going into those conversations. So with those learnings, while that have been my takeaways and the team continues to stay engaged or encouraged with what we have been able to accomplish, this is really the first step, and we have to build upon this and really break this into, if I may say, phases. So our focus over the next 15 months is going to be how do we capitalize and best utilize the interim period and really set the tone and our goals for 2025. And speaking of that, I'm very honored for both Larry Gonzalez for his expertise that he has brought to the consortium and our efforts in joining us today to unpack the process and identify those opportunities that we may want to be cognizant about and capitalize on as we look at 2025. And alongside Larry, I'm even more excited to have Valerie Smith join us, bringing her perspective and someone who has really been, for those of us in Texas, engaged in the health policy primary care space. We have seen Valerie play a significant role over the years, whether it's around addressing non-medical drivers of health, such as food insecurity for high-risk patients, or strengthening primary care. And Valerie, again, thank you for joining us today and bringing your perspective. So to make this or kind of look at real-world implications and charting the course forward, I'll start with our policy, if I may say, offerings or package, and the first bucket, which I think, in spite of the progress that we have made during this session, there are ways to go as we think about solving or bridging that uninsured problem, but also thinking about access broadly. So beginning with access to care, and Valerie, my first question for you is, again, I think Sue spoke about that in the last 4 months, we have had the Medicaid unwinding. Just last week, HHS released their first report from the first phase of unwinding, and it seems that there are 400,000 of those that have been disenrolled that are potentially ineligible because of bureaucratic processes or reasons. They were marked as ineligible and thus dropped off. So when I look at the uninsured number, that's of course going to swell, and probably we are going to be at a point, I'm yet to look at the coverage gap number, but it may be like an even keel when I think about the population that may benefit from Medicaid expansion, but then having the same number of uninsured Texans almost that fall into this bucket of eligible yet uninsured. So when I think about low-hanging fruit opportunities, but also where resources are already available, and again, speaking of 1.99, if you can unpack your experiences this session as you participate in discussions around HB 1599, but more so as we are in this unwinding phase. What are some of those considerations or opportunities we may want to work towards?
Absolutely. Thank you so much, Ankit, for that introduction, and I'm thrilled to be joining you all today. I will just also add in my bio that in addition to the titles that I hold, I am a primary care doctor. 50% of my time is in the clinic at an FQHC taking care of kids who are either uninsured or primarily insured on Texas Medicaid. And so these issues are near and dear to my heart, not just because I love health policy, but because they impact the kids I see and their families every single day. And you highlighted really well the fact that we have a huge number of children in the state. At the beginning of last legislative session, it was estimated to be about 400,000, most of whom are children who are eligible for Medicaid but not enrolled. And with the unwinding, those numbers likely have close to doubled. And so there is a real opportunity here. House Bill 1599, Express Lane Eligibility, essentially allows families to utilize the information they are already submitting to the state when they are applying for other resources such as SNAP, TANF, or WIC to be used to help verify whether they are Medicaid eligible, and if they are Medicaid eligible, would have offered them enrollment in Medicaid. So it's an opt-in system, right? It's not enrolling anybody who doesn't want to be enrolled. And so I think it's really important to understand that had the potential, or has the potential, to enroll a significant number of families and children in Medicaid. 1599 was a really good bill. It kind of sailed through the House, to be quite honest, pretty easily, but then really got stuck in the Senate. And I think there's a couple of things from a policy standpoint to think about there. First is, we need to strategically think about a Senate-focused policy, right, or plan to identify those key allies in the Senate who could help support and sponsor and shepherd this bill, and how we get Senate leadership on board for this bill moving forward. I will also just add, this was the first session that bill had been introduced. And you did such a wonderful job of highlighting HB 12 and the amazing work that happened to get it passed. That was really a 3-session plus effort. And so I actually think the momentum that we have between it moving so quickly through the House and the impact of the Medicaid unwinding leaves us a really nice policy window potentially for 1599. The other piece related to healthcare, and then I'll let Larry take over, is just that again with House Bill 12, one of the things that you highlighted as well is the tremendous amount of human capital that it took from a variety of different advocates, both area specific, but also really healthcare advocates from across the spectrum to help move that forward. There was a lot of heavy lifting that happened this session. I am excited that because we have successfully passed House Bill 12, there's capacity among those partners and those groups to help take up 1599 as one of their key priorities next session. And so I think we'll find a really broad coalition of partners who are actively working to move it forward next session, because there will be some capacity there.
Wonderful. Thank you. I love the ray of optimism, but this is, it's really, it's a work of human equity. It's a perseverance, but also kind of building upon or seizing those opportunities that have been available across or through the processes, and kind of capitalizing on what we may have to take. So with that, I appreciated your perspective on looking at the Senate side. So moving this focus slightly from policy and bridging that with politics, I think, Larry, we have had several conversations, but curious to hear your take on unpacking that. What would it take for us, whether it's on the Senate side, but also probably other opportunities along the way, if we have to turn HB 1599 into a reality 2025?
Again, happy to be here. Thanks for having me. You know, in 1599, I think we saw what happens so often in that building is you don't really know where the issues lie until you, as I say, put it in the grease, right? When you file the bill, that's when all the stakeholders come out. And so in preparation of 1599, it's a little difficult to understand where all those angles were coming from until you drop it, right? And so, given now that we saw, Ankit, was that the one with the fiscal note issue as well, right? And so, I think now we see where the hesitancy was on behalf of some people. There was a fiscal note that we disagreed with, that we were able to provide some really good information to maybe get the fiscal note down, to make it a little more amenable to some folks who saw that number. But this bill is typical in the building, in that, yeah, some of the bigger stuff takes time, but we say that, but it takes time because you have to learn what the variables are that you then have to address. So this session, we got a really quick understanding of where our variables are, who the players are, right? You've got the different members, the elected members, right? And so now we take everything we learned in watching it go to the House and then have a abrupt end over in the Senate. That's the plan, right? And Valerie's right. So we need a Senate option, right? We need to spend some time in the Senate. We have to work with the senators. We have to work with the budget office over in the Senate to talk about these things. And happy with what the House was able to do, but we've got some work to do in the Senate for sure, to find our heroes and our champions who can take this conversation and just go to the other chamber.
Maybe just to slightly expand on that. So as I think about that additional work that is needed in identifying that legislative champion, kind of that engagement, and probably identifying and addressing those questions, both for the consortium, but our partners across the board, are there specific things that you suggest we watch out for or consider pursuing during the interim?
Well, I think everybody on the call has their own strengths with relationships with different members, geographically, politically. You share the groups that are on today have a long history of success and working with so many of those members. This is one of those things where I think you take the relationships built on all the other years and to apply it here, right? So going forward, everybody on the call will need to really dig down into having a conversation with their personal offices that they work very, very well with. The interim exists in Texas. It is used by the members to get ready for the next one, right? So we know there's interim studies and interim charges coming out. I would love for this to be on an interim study, right? For the committee to consider this. Let's have a whole interim study on it. Let's vet it. Let's talk about it. Let's have committee hearings on it. Let's talk about the fiscal note, right? Let's rehash the whole thing and take the bill and put it in a way that we legislate to the possible, right? So that if 1599 as filed wasn't going to pass, is there a way in working with the elected bodies that we can legislate something that is possible and be willing to have those conversations, right? It's not often in my 32 years in the building that you file something and you get exactly what you want. 1 out of 10, you get a 10. This is incremental, right? And everybody on the call today understands that it is incremental. So we need the interim. We need to find our heroes. We need interim charges, interim studies in both chambers. It came out of the House. I'm not so worried about the House anymore, but we need an interim charge in the Senate, and we need the Senate to just air it out. They didn't during session, right? So we need the opportunity to have that conversation. We need the opportunity to work with the senators and explain the details of the policy that the House was able to debate. We need to have that debate in the Senate, and the best time to do that is during the interim, in an interim charge.
Thank you both. Moving further along again with that policy approach. So access to care, as if I may say, I've always looked at it as it's a chronic but very acute in terms of its severity. So it has required the attention. It's not like a one-stop solution that can truly help address the problem. But on the other hand, when we think really about accessibility and sustainability, as I mentioned in one of my earlier slides, that just earlier today, as part of our discussion, we were referring to or discussing a story last night in NBC that now has national attention on shortage of primary care. It was a story about only one doctor in a community in Alabama, and then in New York with 53,000 physicians, but still having a community with no primary care because they are moving to different setting and communities to serve, which really speaks to, yes, part of it is the access to care. You may think about it as a demand supply coverage problem, but the reality is for primary care to be viable for the workforce that's entering the system, for it to be sustainable within those high need communities, rural areas, especially with the state of Texas, about 4 million Texans identifying living in a rural community or an area. We have to have a conversation on revisiting the traditional model of care, which is fee for service, and moving through value-based. And part of it is what is needed from a legislative standpoint in terms of creating that environment for VBC to take place. And I think 1073 was a step in that direction. But also, it is a conversation moving from that episodic, condition-specific to a health outcome specific approach, comprehensive, holistic. And I think that HB 2983 bill by Dr. Oliverson, which sought to test and evaluate the effectiveness of the pilot program that would address food insecurity in those high-risk patients, again, had interest on the outside, were not able to, in contrast to 1599, we still had challenges in seeing it through. And then, of course, not a lot of interest on the Senate side. But this is not new. This work is happening in Texas. This work is happening across the country. There is a lot of data. Texas HHSC has made tremendous progress on its value-based journey. It's recently revealed a plan on non-medical drivers of health does identify food. So I do think this is a conducive environment. The timing is right, but we still didn't see a lot of progress. So Valerie, back to you. And again, given your work, which is what I've been impressed and inspired by in many ways over the years, the work you have done in East Texas around food insecurity, would love to hear your take, both from that community lens, but also your experience as a clinician. And then, Larry, we can come back to you in terms of unpacking the legislative process and approach here.
Thanks. I'm probably preaching to the choir to highlight just what a significant impact non-medical drivers or social determinants of health have on the patients that we care for. About 60% of their health status or health outcomes are really determined by those things and not the care that we provide in the clinic or even can provide in the clinic or the hospital. And so it's really vital, if we care about population health and the health of Texas and the community, to focus on these non-medical drivers of health. I think that Dr. Oliverson's bill was a great kind of first step to try to have the state invest in this. But I appreciate you highlighting the fact that there are actually food as medicine initiatives happening all over the state of Texas right now, mostly funded through philanthropic means. This is a great example of an opportunity for a public-private partnership where philanthropy is helping to create kind of the test bubble, at least here in Texas, and demonstrate that these interventions can result in improved health outcomes and reduce healthcare costs. I mean, I think that's one of the most exciting parts of the literature around food insecurity and food as medicine initiatives is that in addition to improving patient outcomes, there's a really compelling case for it reducing healthcare cost overall. And so actually being a net savings for healthcare systems and for the government, eventually, and society as a whole. And so I think one of our jobs is to think about how do we, and there are some organizations who are working on this, but kind of identify, compile all these pieces and help to tell the story better of what's already happening and what we already know about what's possible in Texas and sustainable in Texas and scalable in Texas. There's really great national data too, but as we all know, we live in Texas and everything is a little bit different here, right? Like we want a Texas-sized plan for challenges. And so I think that is a place where we as primary care have a real opportunity to highlight. The other thing I will highlight, you mentioned the state's HHSC's plan on non-medical drivers of health, which I am thrilled that we have a plan in place. It really focuses on encouraging those Medicaid MCOs to work through plans, develop plans, implement interventions, which I think is excellent. But I want to make sure that primary care doesn't get lost in that. We are the people who have relationships with our patients and who are able to effectively screen and refer and know our communities, right? So we're able to effectively screen and intervene in the clinic. And so there is a piece in that plan that talks about engaging providers and engaging community stakeholders. And we have to be willing to have that seat at the table and really advocate for how primary care plays a really vital role in that. The last thing I will say is that those food as medicine interventions are pretty high intensity interventions for patients who are what I would call high utilizers, right? Who are sick, type 1 or type 2 diabetics, gestational diabetes, uncontrolled hypertension, those types of things. As a pediatrician, prevention is my love language. And so I want to make sure that we also continue the conversation as HHSC fleshes out that non-medical drivers of health plan of that bottom piece of screening and referring for non-medical drivers of health that happened before someone is sick, before we can identify a need before it has escalated into a complex medical condition, and intervene in a way that actually prevents them from becoming ill in the first place.
So well said. And I think, again, it's that opportunity for engagement that we tend to look at like just the regular session, but it's like these opportunities are available, probably that may yield more benefits or have a greater reach if we can just be open about those opportunities and engage ourselves into those places. So appreciate that. Larry, your take on 2983 and whether it's 2983 or the possible version of it as we continue to move forward. But I think the idea is we have to be open. We have to look at those specific programs or models that allow us to or facilitate that broader shift of mentality, this approach from fee-for-service episodic care to this broader whole health prevention-based approach, which 2983 is a step in that direction. So your take and words of advice in terms of charting the course forward. Larry, can you unmute yourself?
Dr. Oliverson's 2983 was fascinating to me. We heard about it, I guess, when he was laying it out in November before session, and it wasn't drafted yet. So we couldn't read anything yet, but he was talking us through it. And my mind was just spinning on, okay, wait a minute. And I began to piece together all the different parts it would take as a former appropriator, right, for kind of the state to invest in things like this. And what does that mean and how would that work? And so it was a fascinating conversation with Dr. Oliverson that I had at our meeting. And then I started looking toward other partners, right? So the Feeding Texas and the food banks had an interest as well. They believe 1,000%, as we do as well, about nutrition and food and nourishing the body. So I think it was a really great bill to look at and study and read. And then the political reality kind of hits in, and you realize, okay, wait a minute, this is a lot for some people, right? So the bill started getting whittled down and kind of pared down, and then it got really whittled down. And I think from what Valerie was talking about, people would always ask me, what's the best way to get something done or the best way to get a bill passed? Hands down, anecdotal. When I'm a member and I'm appropriating for 42 state agencies and I get all this, incredible amounts of paper in front of me, I would always ask the person before they left, tell me a story. Like, I need to hear a story, right? What story can I repeat to my colleagues to where it makes sense? Because remember, the elected members, they're not the experts, right? And so when all the experts are giving me all this incredible data, I needed it boiled down to a little bit simpler. And for me, that was always to tell a story. So I think there's a ways to go with 2983 anecdotally. What I love what Valerie said about the programs already exist in bits and pieces. This was the state's look at it, correct? One of the things that was very important to me as an appropriator was, before investing in something, I needed to see a community or a local match financially. I needed to see some success at another level of government, maybe. And so the history of success, the history of working together, the philanthropic part, that there are people willing to pay for this, is actually, as an appropriator, music to my ears, because that shows to me that there is a huge effort on these types of programs. And the question is, how do we take that and have the state do it? I think we were nibbling all around the edges on 2983. I think 2983 has all the potential in the world, and we're close, and we're talking about it, and we're really around it. But it's a huge concept what he filed, right? And things like this just take time, particularly when it's kind of this scope of things. I hope he comes back with it. I hope he files it again. I hope we have it as an interim study. I hope we're able to drill down. But I will say this: if the as filed version isn't going to pass, I think we need to have a very honest and frank conversation about, okay, but what can pass, and how do we get it started, right? And that's why you see a major piece of legislation that turns into a study in May, right? And then the study gets looked at, and then they come back the next session, and the study turns into a pilot program. And then we see how the pilot program goes, and the pilot program, the next session, turns into a much bigger deal. That's just how the building works. That's not a knock on 2883. It's not a knock on 1599. That's how a lot of this works. So I think it was important that we aired it all out and had the conversation, figure out what is a win, and then spend the interim working toward that. I think 2983 was fascinating to me from a legislative standpoint, to watch all the theory of that building definitely came into play on 2883 from the stakeholder meetings that a lot of us sat in on, right? And kind of how those things would all play out. So it was good to see it play out, but we have a ways to go on 2983.
Wonderful. Appreciate that. And I'm glad we are grounding ourselves into reality of things. I want to be respectful of time, and I do know that going into today's webinar, we already had a series of questions from the attendees joining us. So I want to leave appropriate time for their questions to be answered, and for new questions that may come up as part of the discussion. So with that, Sue, I will toss this back to you to answer questions from the audience.
Thank you, Ankit. What a great discussion. I always learn a lot listening to these people. So we do have a number of questions. The first one is, please advise on effective advocacy strategies in support of Medicaid expansion, in parentheses, closing the coverage gap in a state like Texas. And I would just really amplify what Ankit said and others have said. And I think we need to, I think one of the things Larry has taught us is when you have a win, celebrate that win. And I feel like House Bill 12, extending coverage for postpartum people in Texas, was really just that. It was really a form, if you will, of Medicaid expansion. And I think we need to really stop and feel good about that. Now, I do think we need to look at how that was accomplished. The other thing is, we know that was the third, right? At least the third session where that bill came up. And so I think that speaks to the fact that Larry has been saying, it's an iterative process, and sometimes it takes a long time. And so I think we need to celebrate the wins when we have them. But I would ask either Larry or Valerie if they have anything to add to that.
I would just add, I am an eternal optimist, but I always remember that Arizona didn't implement Medicaid till 1982. And so this is a long game when we think about Medicaid expansion. And each time I see another state implement, and we just saw North Carolina this past week, it is one step closer for us. I think part of the key to Medicaid expansion is that they know what healthcare advocates think about this, and people who are the doctors and people who are in health systems think about it. It really is engaging a wide range of partners, especially in like the business community and other organizations and other sectors who can help carry that as well for us. Because I think, our opinion is on the record and it hasn't moved the needle yet. And so really thinking about how do we engage other partners more strongly in that work is probably key to helping it move forward, even over the long haul.
From the elected official standpoint, every elected official hears things differently. And so it's not uncommon to message the same bill 2 or 3 or 4 different ways in a language that the elected official can receive it, right? So it's not just the one answer or the one spiel. It's really understanding how each member needs to hear it. I'll give you an example. There were some really, really great SNAP bills that passed this session that had been tried 5 sessions in a row. The governor signed all of them this time, right? The governor signed them. And it took us a while, but it also took a little bit of understanding the messaging for the particular audiences, right? In a way that they could receive it, understand it, and get on board. So sometimes adjusting the language, adjusting the messaging, the body changes, the members come and go all the time. And it's learning how to state it in a way that they can hear it and get on board, right? And sometimes in the case of House Bill 12, the politics are just right. The politics were right in a session where we knew going in women's health was going to be a priority. We knew that going in. And sure enough, House Bill 12 finally catches the political momentum and it gets done. So there's all kinds of wins out there, and I think sometimes you have to find the tailwind and on some of these things and just get on board and find those opportunities.
Excellent. So the next question is, research on primary care in communities shows equity in value. What will it take to move upstream in healthcare and primary care? And Valerie, that's got your name written all over it.
It is where I live. It also is, I think, a huge challenge. I do want to note one win that we didn't mention earlier today is that we did in the state of Texas have the first Medicaid rate increase this session in 20 years. And so the state has indicated, and specifically Representative Jeton, who was chairing that portion of the budget committee, really helped to carry that and has become somebody who I think really is a strong advocate in the Capitol for us on the importance of primary care and the importance of a strong Medicaid system that serves Texans well. And so I want to just highlight, as we're thinking about wins, that is a win that we haven't highlighted yet, that I think is something that we can look at to build on. We've mentioned a couple of times before the importance of value-based care. And I do think really looking at how the state, where legislatively we need space that would allow HHSC to more fully embrace value-based care, and even TDI, the Texas Department of Insurance, right? So this isn't just Medicaid, this is private payers as well, to more fully embrace value-based care that allows physician practices and clinics and hospital systems to get funding for the work, much of the work they're already doing, but that's providing high value preventive care is going to be really key over the next several years for us.
I'm glad you mentioned Representative Jeton to kind of prove my point, and you prepare all the interim for a session, right? If anybody tells you that they thought that Chairman Jeton would be chairing Article 2 in the House, they're not being honest. I mean, nobody saw that coming, right? So there's no prep time working with the chairman for a year and a half. When he got Article 2, that was kind of a surprise to a whole lot of people. But once there, we now know who our champion is. We now know that he's on our side on much of these things as a Republican. He has turned into somebody that a lot of people are like, oh, who's that guy, right? Who's that guy? And so he can be a help for us now. We wouldn't have thought that 2 or 4 years ago, but now we know. So looking forward to working with him during the interim, looking forward to working with him as he builds the budgets for Article 2 for all those agencies he's responsible for. But now we have a point person that we can really look to and work closely with on these issues during the interim heading into 2025.
Nice. Good. Here's another one. Was there any legislation that supported a high level of coordination of care with behavioral health specialties? Do y'all want to address that, or anybody?
So I do know that there is a specifically can't recollect a bill number per se, but know that there were opportunities during this session and interest across the aisle in, I think the approach mostly taken was around mental health. You see that kind of baked in, or behavioral health getting baked in. So maybe I'm optimistic or positive that there are a couple of opportunities there. But to be objective, we are happy to review some of those bill actions and unpack that a bit and share that as part of our ongoing exchange and communication with this broader network. But whoever submitted this question, if you have a specific interest, please reach out to one of us. You have our contact information here, and point you in the right direction.
Good. There are two questions that are kind of related. One is, what can we do to increase access to healthcare in Texas? And the other one, which is also, I think, important and related, is what is the consortium doing to assist the number of medical students going into primary care as a practitioner? Valerie's nodding her head. There's such a shortage. This is a critical component for the future. So we have a great role model right here who is a medical educator and no doubt inspiring new generations of pediatricians and others too. So Valerie, that's for you.
Thanks. I have the privilege of being at the newest medical school in Texas that was really built in East Texas for East Texans. Our entire class essentially is from East Texas, with the hope that they will stay here. As many of them as possible will stay here and practice to fill mostly those large primary care gaps that we have in the area. The state has done a nice job actually of investing in the primary care preceptorship program. That is something that I would highlight that helps medical students have very early access to clinical experiences in primary care to help light that fire in them. And we saw continued investment in that this session. And so I think that is an important piece that of where the state can, is helping to play a role and helping to support that. We do also need to recognize that primary care is hard work. And maybe I say that because I do it, but I think sometimes we undervalue the extent of work that primary care does. And so one of the things I think that we need to think about broadly is not just how do we train and recruit primary care docs, how do we keep them? How do we keep people from burning out and keep them able to practice a full span? And there are, I think, a number of opportunities that we could invest in that would help us with retention, especially in high needs populations.
Valerie, thank you. And so, since the question was in part to the consortium, I won't repeat what has already been shared. But again, when we think about access as a consortium, we look at it very broadly. So while insurance coverage is one part of the problem, and we have already spoken on things we have done and we seek to do, we also need to make sure that it is not the only part of the problem. We need to make sure that there are enough physicians and facilities or the appropriate settings for this physician to deliver what we call as high quality primary care. And again, part of it is the reimbursement. So again, HB1 did account for Valerie. Thank you for calling that rate increase part, which helps with network adequacy slightly. But again, it's sort of tip of the iceberg. And then there are opportunities with telehealth, or other infrastructure pieces. That's within access to care. So looking at it beyond one dimension, and the consortium is committed to advancing efforts in that regard. When you think about how do we make primary care attractive, part of it is, Valerie, what you have spoken to, but unless and until we shift the economic realities around primary care practice viability and what we seek from primary care, but then what we end up paying or what they get paid for, there is a contradiction there. So as long as we don't overcome, we will not be able to make it attractive, and we are committed to slowly and gradually flip that story. But Sue, just want.
No, thank you. And I know we need to wrap up, but I do want to acknowledge there's a couple of questions about the role of nurse practitioners. And what I would say to that is that Texas Primary Care Consortium is committed to the team-based concept of care. We believe that all members of the healthcare team are valuable. They all bring their unique skills. And in order to meet the access needs in Texas, we need to really fully utilize team-based care. So thank you for those questions. And thank you all. We hope that you'll follow us on Twitter or X, like our Facebook page, and subscribe to our newsletter. And hopefully we'll see you at our summit in November. There you go, just on cue. So it's going to be a wonderful summit, November 2nd and 3rd in Houston. And we hope to see you there. And thank you, everybody. Thanks to our panelists, thanks to our staff, and thanks for everybody for joining. Thanks a lot.